All right, so we'll just go ahead and get started. That way, hopefully we can end a little bit early and you guys can enjoy the long weekend. So happy Friday. Thanks for everyone to being here prior to the start of the long weekend. I know myself and all the other residents really appreciate it. So today I'm going to be presenting on the use of motor imagery for chronic low back pain. Sorry, the use of graded motor imagery for chronic low back pain. The clinical question I'm going to attempt to answer through this presentation is, I didn't even, sorry. So I'm going to try to answer, what is the effect of utilizing motor imagery compared to therapeutic exercise in patients with chronic low back pain? Here are objectives for your reading pleasure. I'm not going to read through them just because that would take some time. So without further ado, let's get started. So chronic pain, a word we are all almost too familiar with, but just some statistics to get us started. Next to the common cold, low back pain is the most common reason that individuals visit a physician's office. It costs billions, and that's with a B, of dollars in medical expenses and lost labor costs each year. And there is a high lifetime prevalence and reoccurrence rate. Now, in true residency fashion, I had to address the CPG for low back pain, and I just wanted to briefly review the categories that exist for chronic low back pain. So starting off the list, we have chronic low back pain with movement coordination impairments. Now, I'm not going to read each one, but I wanted to highlight where therapeutic exercise was recommended in each of these. So for movement coordination impairments, the CPG recommends therapeutic strengthening exercises to address trunk and pelvic region muscle strength and endurance deficits. Following that up, we have chronic low back pain with radiating pain. Again, they include a general recommendation of Therex to address thoracolumbar and nerve mobility deficits. And finally, we have the subgroup that I hypothesized would benefit most from graded motor imagery, and that's our friends with chronic low back pain and generalized pain. Current recommendation of treatment is education, most likely in the form of pain neuroscience education, and then low intensity prolonged exercise activities. Now, I did not specify in my title which particular grouping of patients this lecture was going to look at, because as I did my research, I realized that there just isn't enough literature available out there yet to discern which category of patients would most benefit from a graded motor imagery program. And as we all know, research articles rarely subgroup their patients according to the CPG. Therefore, I decided to keep it as general as possible. And then we're just going to call it general chronic low back pain. All right, now that I can feel good about having that established, let's get into some changes we see with chronic low back pain. So with patients who have chronic low back pain, we start to see these structural changes, specifically in the form of brain atrophy or a decrease in the density of brain gray matter, impaired motor control of spinal muscles, which implies maladaptive brain plasticity of motor control related areas, and then the reorganization of motor control related brain areas or the smudging of the motor brain. And then lastly, we see decreased lumbar tactile acuity and proprioception. This is not an all-encompassing list by any means, but it's going to be our jumping off point for this lecture. Now, I'm not going to even pretend like I know how to adequately explain what those first 3 bullet points mean, but I will show you some examples of these changes, which I feel like is going to be easier for all of us. So this was a neat little study done by some very intelligent people entitled Extensive Reorganization of Primary Somatosensory Cortex in Chronic Back Pain Patients. So they looked at 10 subjects who suffered from chronic back pain, and then they had 9 aged and gender matched controls who obviously didn't have any back pain. Basically what they did is they placed electrical bipolar pulses at 2 different sites. So one over the left side of their back, about 3 centimeters lateral to the spine at the level of L3, and then the other one on the tip of the left index finger. Then they electrically stimulated their back and their index finger, and they used magnetic source imaging to assess the cortical responses to the peripheral stimulation, basically looking at what part of their brain lit up as the finger and back were stimulated. Simple enough? Well, just in case, here's what that looks like. So as you can see, the mapping for the healthy controls are the circle and the triangle with the black outline. So they're kind of more lateral to the midline of the brain. And then the mapping for chronic low back patients are the shapes without an outline. So what they found is that the cortical representation of the back in subjects with chronic low back pain had shifted more than 2.5 centimeters immediately, which signifies extensive reorganization of the primary somatosensory cortex in chronic back pain patients, and it might indicate an expansion of the back representation into neighboring foot and leg areas. So we're all familiar with this picture, and essentially it means that there is a medial shift for the trunk representation. It should be about where the arrow is pointing, but it has moved inwards toward the area for the knees and toes. And I know we all know that rarely ever do we get someone with just back pain that also doesn't go down into their butt, legs, etc. Another example of some of the changes we see in chronic back pain is with proprioception. So this study was titled Lumbar Repositioning Deficits in a Specific Low Back Pain Population. They looked at 15 individuals with chronic or recurrent low back pain greater than 3.5 months. And then they looked at 15 individuals without chronic low back pain. They used an electromagnetic device titled the 3-space fast track model, and it measures the position and orientation of a sensor in space relative to a source. So they put sensors all over the backs of these patients, specifically at T12, L2, L4, and S2. And for the experiment, they sat them in a chair. So they ended up looking like this. They moved them through full lumbar flexion and extension 3 times, and then they placed them in a neutral spine position and held it for about 5 seconds. They define neutral spine as just the spinal position between end range flexion and extension. So I guess just halfway between those. They didn't really specify exactly how they measured that. But then they had them fully relax into lumbar flexion for 5 seconds and then asked them to reproduce the spine neutral position. And they measured the error. And what they found was that people with chronic low back pain had significantly greater repositioning error compared with the controls, meaning they had a much harder time finding that neutral spine posture. One reason that I included this study and that it's significant, there have been a lot of studies out there that have looked at this with patients in standing or in quadruped, but this study actually looked at patients in sitting, which which makes them rely more heavily on their vestibular system, which decreases the ability for them to rely more heavily on their vestibular system or their lower extremities. So they really just have to pay attention to what their back is feeling. Okay, so now we've established all the negatives associated with chronic back pain. You're probably thinking to yourselves, can we fix it? And instead of just shouting, yes, we can, I'll answer that with a study. So in this study, they looked at MRI imagings of patients' brains before and after either spine surgery or facet joint injections, and they found that the brain abnormalities typically found in patients with chronic pain were able to be reversed. So after treatment, the MRI showed a restoration of the brain atrophy or the brain gray matter volume, and they showed changes in the function or the brain activity and cognitive tasks, which is phenomenal news that these changes aren't permanent. I didn't want to get too in-depth into the study because they looked at surgery rather than physical therapy, but it was the only low back pain study that I could find with functional MRI changes. Also, the outcome stated that the brain changes happened because they were treating the chronic pain and decreasing pain levels, which changed their brain afterwards. So not necessarily because of the surgery, just because they got rid of the pain. Hopefully that translates to if we can decrease pain levels in our patients with therapy, we should see the same results. Okay, so now that we know these changes happen in the brain because of chronic pain, these changes are not permanent and they can be reversed, which begs the question, can physical therapy create these changes? I bet you all know what's coming next. Another study. So this study looked at 20 right-handed volunteers with sustained non-specific low back pain for greater than 3 months. And their criteria was that the pain must be sufficient enough to limit their activities of daily living. They then divided these patients into 2 treatment groups, either skilled training or walking. So the 2 weeks of skilled training involved voluntary activation of the transverse abdominis independently from other trunk muscles. So they placed the subjects in crook lying and instructed them to either draw their navel towards their spine, draw their abdomen away from the waistband of their pants, flatten the lower abdomen, or contract their pelvic floor muscles. And then a therapist would palpate the TRA over to make sure that they were contracting it. Once they were able to activate the TRA with minimal activity of other abdominal muscles, they held the contraction for 10 seconds while continuing to breathe. And they were instructed to perform 3 sets of 10 reps twice per day. So for the exercise group, they were instructed to perform 2 weeks of walking at their own pace for 10 minutes twice a day for 2 weeks. They used transcranial magnetic stimulation to map where in the motor cortex they were seeing that this max voluntary contraction of TRA, and they used forced expiration to try to figure that out. And they looked at it both at the start of the study and then after 2 weeks. And here's what they saw. So the skill training induced this lateral and medial shift of the representation of the trained muscle at the motor cortex over both hemispheres, which means that after the training, the mapping of chronic low back, or the mapping of the TRA of patients with chronic low back pain more closely resembled that observed in healthy individuals. And they had done a study prior just to see where it did pop up in healthy individuals. And they saw, so if you look at like that top, those top 2 images, the pre and the post, you see that the post is kind of shifted up more. And that's the image that more closely resembles those healthy individuals. With the group who just completed the walking, there really wasn't a change in the representation of the motor cortex. So while this doesn't show a change in brain atrophy, it does show a change in the motor cortex mapping, which is still a big win for physical therapy. And then, okay, so this study isn't great, but it was the only systematic review that I could find that specifically looked at cortical reorganization in chronic low back pain. And they wanted to know the effectiveness of treatment modalities which specifically target cortical reorganization in the management of chronic low back pain. The interventions they looked at were graded motor imagery, mirror visual feedback therapy, and sensory discrimination training / tone pitch recognition. So after their lit review, they were only able to find 5 usable studies that matched their criteria, and 2 of them have been included in this presentation. So if that lets you know how small the research pool in this area is. One of them was discussed with the transverse abdominis, and the next one, or the other one, we'll talk about with mirror therapy. But as far as what this systematic review found, they found that controlled interventions can significantly influence cortical representation or neuroplasticity and appear to facilitate correction of pathological cortical mapping towards the agreed norm, which we knew based on the transverse abdominis study. And then they also found that real-time lumbar visualization using mirrors may significantly reduce the severity and duration of movement-associated low back pain, which we'll find out about later. As far as the sensory discrimination, retraining and tone pitch recognition, there really wasn't much of a change, but it's not what we're looking at in our presentation. So for our purposes, that really doesn't matter. Also, again, remember that this wasn't a solid systematic review and these findings were really generalized, so proceed with caution. They didn't have specific evidence or data to really back up these claims. They just made a generalization based on what they were able to find. And now, the moment you all have been waiting for, graded motor imagery. So what is graded motor imagery? This is a comprehensive program designed to sequentially activate cortical motor networks without triggering the protective pain responses. Full disclosure, I got all of this information from their website, gradedmotorimagery.com, which is why it's going to be listed at the bottom of all these slides. It was either use like the minimal amount of information from their website or pay $50 for the book. And I was not about to do that. So this is what we're working with. Also, I am in no way promoting the book or the app, which I'll talk about later. I'm definitely not sponsored by them, and I have zero gain or incentive to put their website all over this presentation, other than my options were limited. So there are 3 stages to graded motor imagery. The first is left and right discrimination, or the ability of the patient to identify left or right images of their painful body parts. The second is explicit motor imagery. This is one we're all probably more familiar with, but essentially thinking about moving without actually moving. You know, the whole mental practice or mental trials count. I can't think of the phrase right now. But so for example, thinking about bending down to touch your toes without actually doing it, or thinking about walking up the stairs without actually walking up the stairs. And then the last part is mirror therapy, where patients can use the movements of stronger body parts to trick their brain into thinking that the weaker body part is moving using a mirror. It's commonly used with like amputated limbs. Now, before starting this project, I had heard of the last 2, but I hadn't really heard of the left-right discrimination aspect of motor imagery. So I included the short video found on their website that explains how patients go about doing this. And fingers crossed it actually works. So, and it's a little bit behind, like the video's behind what he says, but it's fine, you'll still get it. And then if you could just give me like a thumbs up if you can hear it. No, dang it. Okay. Well, so I'll try to explain it. So basically, they're given these pictures and it will either show like a left hand or a right hand, and the patient has to wait. Why thumbs up now? Did it work?
I could hear it.
Try it again. Sorry.
Okay. Right. All right. We're going again. Gina, you give me a thumbs up. Oh, what just happened?
Testing and retraining with drug discrimination. Brain training practice, comprehensive assessment and treatment tools to lift drug discrimination.
Sorry.
Monica, now it's gone.
All right. Well, anyways, so basically they're given a picture of a left and a right hand, and the patient has to decide which is the left hand or which is the right hand. And they basically can just, let's see if I can just show you. Okay, so you see these little arrows. Basically they pick if it's left or if it's right, and then the app itself calculates how well they did. Okay. Let's see if it'll show me. So yeah, it can assess like how accurate they were with their lefts and their rights. So now that we are well versed in what graded motor imagery is, let's see it in use. Since I have not had the opportunity to use it with one of my patients, let's look at someone who has. So this case study is wonderfully named Monkey See, Monkey Do, using graded motor imagery in the management of chronic low back pain case report. All right, so a 33-year-old male presents to physical therapy for the treatment of chronic low back pain that he's had for the past 10 years. 5 years prior, he had an L4, L5 discectomy and laminectomy with complete resolution of radicular symptoms for 1 year. After 1 year, his pain symptoms increased and sometimes left him bedridden for days. Thus began cycles of increased pain, unpredictable responses to activities. He also had bilateral numbness and tingling from his butt down to his posterior thigh. He denied any changes in bowel or bladder function or other red flags. They also noted some of the things that he had said in his initial eval, such as I could stack firewood or carry concrete bags up the stairs with no problem. However, if I walk on a concrete floor or bend down to tie my shoes, I'm crippled for the week. Or I am structurally damaged and I have to protect my back, which alarm bells should be going off in everyone's head. And then his goals were to avoid another lumbar surgery. So they didn't see any significant limitations with his lumbar range of motion, but they did note a high activation of trunk stabilizing muscles with lumbar flexion. He had a 5 out of 5 strength in his lower extremities and a negative neuroscreen. On his outcome measures, he reported a 42% on the ODI, which is classified as high disability. On the FABQ, he reported a score of 16 out of 42 on the work subscale and 20 out of 24 on the physical activity subscale. There aren't any standardized norms that I could find for the FABQ, just kind of the higher the number, the greater the probability of that fear avoidance behavior and how it might affect the clinical outcome. So laterality recognition, it was assessed using the Recognize app or the failed video that I just tried to play. And then an accuracy is defined as 80% above is considered normal. His left accuracy was 60% and his right accuracy was 68%. So these scores indicated an inability of the patient to distinguish his left from his right side, suggesting that cortical reorganization had occurred, but they don't know that for sure. And lastly, they confirmed a diagnosis of central sensitization based on patient's history, the cyclical pattern of pain, and patient's misconception of pain, which if this was my patient, I would still have classified him as central sensitization, But my reasons would have been the unpredictable patterns of pain, not necessarily the cyclical patterns. His pain is disproportionate to the injury, which was labeled as a disc herniation, and he's getting pain all the way down his legs. And then the maladaptive behaviors, which I'll give him a point for because they put pain misconception, kind of the same thing. So treatment wise, they started with pain neuroscience education videos, and then detailed examples of those will be given on the next slide. From a graded motor imagery aspect, they included a laterality recognition training, advising the patient to begin using the Recognize app, deciding like left and right of his back. But they didn't specify how often he did it. They just told him to use it daily. For explicit motor imagery, they had the patient think of other people performing lumbar flexion, and they picked people that were like non-threatening to him. So for example, they said, imagine Homer Simpson bending forward to pick up a donut. And then they progressed to him thinking of himself performing pain-free lumbar flexion. And they told him to practice this for 5 minutes every day on his lunch break. He said that it took him about an hour to do this because he had to, get himself in the right headspace before he was able to actually think about people bending forward or himself bending forward without his back hurting. For stress and anxiety management, they recommended using the Headspace app along with diaphragmatic breathing in prone and hook lying. And then because they wanted us to have zero idea which treatment actually changed his pain, they included graded exposure for pain-free lumbar flexion without engaging trunk stabilizing muscles and walking for 15 minutes every day. So this is the treatment. If you want to look at it, it just kind of goes over what videos they gave him, like the why do I hurt? Ooh, sorry. And then others. I'm not going to read it because that's a lot. So how did he do? So this graph shows his ODI and laterality accuracy scores over 4 visits. As you can see, as his laterality improved, his ODI score decreased, and he actually did get up to like 196% on the laterality app. His FABQ score also decreased. For the physical activity subgrouping, he went from a 20 to a 12, and for the work subgroup, he went from a 16 to a 9. But remember, they did like 6 different treatment programs, so I can absolutely not say that it was graded motor imagery that caused these changes. But I mean, this was an interesting way to approach someone with chronic low back pain, and he had tried physical therapy before and it hadn't worked, and this did for him. So because this presentation hasn't included enough studies, the previous case study included the first 2 parts of graded motor imagery, but lacked the mirror visual feedback component. So I decided to throw this study in here because it includes an example of how to use mirror therapy with low back pain. So this study is titled Seeing It Helps, Movement-Related Back Pain is Reduced by Visualization of the Back During Movement. They included 25 chronic, non-specific low back pain patients who had experienced back pain for a minimum of 6 months. Then they randomized them into 2 groups, either visual feedback or no visual feedback. For outcome measures, they used the VAS and looked at pain intensity of the back, and then they also looked at time to ease, so how long it took for the back pain to go away. For the visual feedback component, they marked each spinous process of the lumbar vertebra. They marked iliac crest and they marked the 12th ribs. They then asked patients to move as comfortably as they could into full lumbar forward flexion, extension, and then left and right side bending without bending their knees. They measured the distance of their fingertips on their legs, and they marked it with a pen so that they would be able to make sure that each patient went through that same exact full motion when they did the testing. And then they brought in 2 mirrors. So they put 1 mirror in front of them and 1 mirror behind them, so that patients would have a full view of their back in the mirror. For the visual feedback condition, patients were instructed to perform 10 reps of forward flexion, extension, and side bending while watching their reflection in the mirror. The time was kept constant by a metronome, and someone watched to make sure their fingertips hit the marks each time, ensuring full range of motion. And then for the subjects who didn't receive any visual feedback, everything was kept the same. The mirrors were even there. They just put a sheet over the mirrors. And they were instructed to look at the sheets instead of the mirrors so that their heads were in the same position as the other patients. So patient averages prior to treatment were a VAS score of 46.8. Disability was 10.4, measured using the Roland Morris Disability Questionnaire. Pain catastrophizing score was 18.8, measured using the pain catastrophe scale. And then they did the hospital anxiety depression scale, and their average was a 4 out of 21 and a 7.1 out of 1 for anxiety. And it worked, actually. So as you can see, patients who had visual feedback reported about 10 points less on the VAS, and it took about half the time for the pain to go away, which is great. So looking at this graph, that first line with visual feedback, post-movement pain intensity was they marked as a 35.5, and then without visual feedback, it was a 44.7. And then how long it took for the pain to go away, they just, as soon as the treatment was over, they laid the patients in comfortable hook line and just timed it until the pain stopped. And for the people who received a visual feedback, it only took 44 seconds. And for the patients who didn't receive visual feedback, it took 94 seconds. So maybe there is something to this after all. But again, this was just one part of the graded motor imagery plan, not the whole thing. And these are literally the only current studies that have looked at aspects of graded motor imagery in patients with chronic low back pain. So that's on me for choosing such a new and experimental treatment to research. They have done it with patients like chronic shoulder pain and things like that, but I chose back pain, so I decided not to include any of those. So I know that was a lot, but just to sum everything up, we know that changes in the brain occur with chronic pain. We know that these changes are reversible if we can decrease pain. We can decrease pain with therapeutic exercise, and maybe motor imagery works, but also maybe it doesn't. We don't know. So looking ahead, a lot more research needs to be done, not only on the reversible changes with chronic pain, but also on if therapeutic or graded motor imagery can actually produce these physiological changes in patients. I think that there's a lot left for us to explore with chronic pain, and that there's some exciting and great new treatments coming our way for our patients. Thank you. And now I'm very tired of hearing myself talk. So if anybody has any questions, I am happy to take them.
Hey Gina, it's Kenzie. I like low back pain. Cool. So that was a really good presentation. After you've dropped some of your pain education nuggets on the patients, what are some of your initial ways of introducing, all right, we're going to do some graded motor imagery. They might not seem receptive, like, hey, we're gonna just do this motion. You're gonna watch yourself, and by doing this, that gets you better. How do you introduce that?
Yeah, that's a great question. I haven't actually done it, but I can imagine that I like to approach it based off of like research. So things that I know to be true. So approaching it in a sense like, hey, you know, they found that people who have chronic low back pain have a tough time recognizing, you know, their left and their right side of their back. I have this fun little app. Let's see if, you know, maybe it helps solve your pain if I can get you to understand which side of your back is your left and which side of your back is your right. Or for the mirror, you know, hey, sometimes people don't know how their back looks when it moves, and if they can see their back moving and see that, you know, no harm is coming to it, it helps ease their pain. So again, just coming at it from like the approach of we're changing how your brain perceives pain rather than, you know, we're actually changing something that's wrong with you. So like damage. That would be my guess on how I would approach it. I don't know. When I try it with a patient, I'll let you know how that treatment or how that approach worked and if I need to modify it.
Thank you.
Hi, Monica. Good job. I have a question because I took this like process with one of my patients. She has like widespread pain, and we started off with the laterality app, and she did like really well on that, but had trouble with everything else. Have you seen anything that helps you with like pacing and dosage? Like, is it worth it to keep doing that? Like maybe she was just having a good day or anything like that? Because I just kind of like skipped ahead.
Yeah, so with like the couple of case studies that I've seen, what they typically did was they started like really, really slow. So just like 5 minutes a day. So making this like a very simple thing for your patient to do. So like they only have to take 5 minutes out of their day to start like thinking about other people bending their back. Or like, you know, you take 5 minutes of your treatment and you're like, hey, why don't you, while we do this one exercise, why don't you watch your back? You know, just keeping it like really light and simple, not trying to get them too bogged down. But also I like that they included those pain neuroscience education videos, because I think that sometimes that's easier for a patient to understand rather than us telling them, you know, what works for us. They're able to do that in their own home and watching those. So most of the treatments or most of the case studies that I saw, they included some sort of pain neuroscience education. So maybe just like starting with that and then easing your way in to the more of like the laterality and the graded or in the explicit like motor imagery, thinking about themselves moving.
Thank you.
So Monica, with this kind of being a very specific treatment approach, how would you go about explaining this to a patient if you're choosing to do it specifically, since it's not what we typically go to first when we start to think about, you know, chronic low back pain? How would you kind of sell this to your patient?
Yeah. So I think, again, that I would try to probably honestly use the research, you know, just like letting them know like, hey, sometimes patients or someone who has had pain for a while, their brain has a kind of a tough time figuring out what parts of their brain should light up when you move certain things. I probably wouldn't get that specific into it now that I'm saying that out loud, just because people would take that and run with it. But I forgot your question. Can you repeat it?
Just pretty much the idea of how we'd go about explaining this to a patient if we were to do it. Because if you
Okay.
came to me and said, I want you to think about moving your back, I might think you're crazy.
Yeah, that's fair. So I guess like coming at it from like more of a pain neuroscience approach. So being like, you know, sometimes just because we do or we think about moving, it still counts as actually moving. You know, they've done studies to where mental repetitions count. So thinking about wanting to move your arm counts as actually moving your arm. You know, you're still getting those parts of your brain lighting up that signify that you have moved your arm. So kind of coming at it from that approach. And I think that this is something that I would use with the patient, not my first treatment session. You know, I think I would start out with, okay, let's do some pain neuroscience education. Let's do what's recommended in the CPG. Let's do some long, low intensity therapeutic exercise. But if nothing was working, maybe being like, hey, maybe we need to take a different approach and like address it from this area, because people with chronic low back pain do have deficits in all these areas. And maybe if we can fix these deficits, your back's going to start to feel better. You know, I don't have enough evidence to say that this is going to be something that is going to change a patient's life. And so I would never approach it like that, because I'm still not sold on it totally.
Yeah, it's kind of, you look at, if you go back to that previous study you had, and you look at the confidence intervals, forward. One more.
Oh, this one.
Right there, yeah. You kind of
Yeah.
look at, you know, what do those confidence intervals speak to you when looking at the statistics?
Like, those are pretty wide confidence intervals, you know, so they're not really actually sure that it did work. They have, I mean, it looks promising if you just take that, but yeah.
Yeah. And that's kind of where I think with the articles, it's getting in and reading the statistics, because, you know, nice graphs, you know, can sometimes be deceiving, but, you know, like you mentioned, you know, there still needs to be further evidence out there. A way that I've tried to go about it is I will have the patient just do the app for fun in front of me and kind of show them how, oh, you scored an 80% on your right versus 30% on the left. Especially, I was playing around with it with a few post-op ACLs early on, and there was definitely a trend there that I saw. So I think just in terms of, for me, trying to convince them, it's instead of convincing, let me show you that there might be something that you need to work on, if that makes sense.
Yeah, no, definitely. So did you just like buy the app and you have it on your phone and you'll pull out your phone?
Yeah, I have the app on my phone.
Cool.
So
Thanks for sharing.
I also do have like a free trial for patients. If you want them to like try it at home or whatever, they can like download it and try it. I think it's like a couple times we were looking at it.
Oh, cool. I honestly saw that it was $5 and I was like, no, I'm not gonna do it, but glad to know that.
There's also an app called Orientate.
Ooh, does it do the same thing, I'm assuming?
Yeah, it does left and right hands, feet. And it all is like I think like further pieces too, but you have to pay for like the further parts.
Okay, cool. Orientate. Got it. Thanks.
You had also mentioned something about like FABQ cutoff and that you're kind of like, oh, I'm not really sure what's high or not. There is a cluster for it's different. So hear me out. There's a cluster for a thrust manipulation for like acute low back pain. I think by Flynn et al. And it's the items on that cluster are duration less than 16 days, proximal to the knee, hypomobility. One hip has greater than 35 degrees of internal rotation, and a FABQ work subscale less than 19. I know that you can't really take that number and now go, okay, someone, if they're FABQ less than 19, that's a good thing. It's kind of how you can apply it, but considering that we don't have established cutoff for it, I think it's maybe worth thinking about 19 as kind of like an, okay, somebody else has already established that there's something about 19 less than that, which makes them likely not as fearful and not as about movement and manipulation. So maybe that would be helpful.
Yeah, definitely. That was the only thing that I could find, but I was like, we're not looking at manip, so I won't include it. But I honestly hadn't thought about that in the context of thinking about the number 19 and being like, okay, 19 is something to keep in mind. But thanks.
And one more thing. Sorry, I like low back pain. You brought up a study at first that used like the cortical remapping as the outcome of your transverse abdominis training with chronic low back pain. I thought it was really interesting, and I liked that because if you go on social media, there's definitely like two big camps of. There's one camp that like really poo-poos TRA training with low back pain. And don't ask me for references on why they think that. I know that there's a couple studies out there but I think they looked at more like TRA training as the main intervention and a part of the intervention selection. But I like that it was approached from like, well, that helps you cortically, remap the areas, which then helps to reduce back pain. I think that camp really poo-poos TRA training, like who cares if that muscle's active? It's not really stabilizing anything anyway. I don't know what they say. I don't listen. But I like that it went from that perspective.
Oh, thanks.
Okay, I'm done.